Fortunate today to have Dr. Kathy Forster, a consultant cardiologist from St Vincent's Hospital in Sydney. I first heard Kathy speak at a research event last year, I think it was, and she was speaking on this exact issue, women and heart disease, and I was so blown away by what she said and the statistics that I thought we really needed to get her here to share her insight with all of you today. So please welcome Kathy.
Thanks, Sophie, and thanks everybody for inviting me today. As you've heard, heart disease is the most pressing health issue around the world, in developing and developed nations alike. Heart disease kills 1 in 4 Australian women, 3 times as many women as breast cancer, and as you've seen, more than all of the cancers combined, but it doesn't scare anywhere near as many women. As a heart specialist in clinical practice, I see firsthand the impact of heart disease on men and women, and it's a real pleasure and a privilege to be able to share some of that information with you today. At the World Congress of Cardiology in Melbourne 2 years ago, I was lucky enough to listen to a lecture by a lady called Professor Nanette Wenger. She's now in her 80s, and she has been conducting insightful and innovative cardiovascular research since 1959. So she's been doing this for a while. And she made a really important point. She said, heart disease doesn't discriminate. It's an equal opportunity killer. The female heart is equally vulnerable, but heart disease in women has been under-recognised, and as a result, it's been undermanaged and underfunded. In 2004 to 2005 in Australia, 20% less was spent on women with heart disease compared with men, and there have been significantly worse clinical outcomes for women. One of the main problems that we struggle with is lack of awareness in women. Now, cardiovascular disease is perceived as a man's disease, and as such, women are not checking their risk factors. They're less aware of the warning signs, particularly the less well-known warning signs, and when something happens, they're less likely to get help. When questioned about cardiovascular risks, women tend to be quite good about knowing that smoking is risky, that being overweight or inactive is risky, but only 1 in 10 mention high blood pressure as a risk factor, and only 1 in 8 mention high cholesterol, and these are really important risk factors. When asked the first step that they would take if they thought they were having a heart attack, only 53% of women said that first step would be to call an ambulance. And I think that really illustrates the complete lack of understanding and lack of awareness of just what a dangerous thing heart disease and heart attacks are. Adding to this, many risk factors for heart disease are silent, quietly causing damage if they're not checked. Ooh. That's supposed to say cardiac risk factors. In Australia, 90% of women have at least one cardiovascular risk factor, and over 50% have 2 or 3. While men and women share the same risk factors, most of these factors confer an increased risk, relatively speaking, for women. Smoking is associated with a 25% higher risk of coronary artery disease for women compared with men. Smoking triples the risk of heart disease for women, and it increases it by a factor of 7 for women who smoke and who are on the oral contraceptive pill. The cardiovascular risk of diabetic women is double that of diabetic men. High blood pressure is the leading cause of cardiovascular mortality worldwide, and again, it confers a doubled risk for women compared with men. Cholesterol imparts the highest cardiovascular risk for women, increasing the risk by 47%. We know from the research that we do have that the benefits of statin therapy are the same for men and for women, but statins are prescribed less frequently to women. So there are lots of women out there who should be on medication who are missing out. Obesity increases the coronary risk for women greater than it does for men. And this is a real problem in Australia, where we see that for people as young as 35 to 44, it is more common for women to be overweight or obese than to have a healthy weight, and that figure is continually increasing. And finally, depression is associated with a higher cardiovascular mortality for women than it is for men. The complications of pregnancy are also really important warning signs that we're only just getting more information about now. It's been said that pregnancy is the first vascular stress test that a woman undergoes. And we see high blood pressure, high blood sugars, or preeclampsia are all warning signs that that woman is at risk of cardiovascular disease in the future and needs really close screening, needs education. And I think it's really important that we recognise this and that we harness the resources that we have early to try to prevent cardiovascular disease in these high-risk women. If we actually do this, this is an area where we can definitely save lives. Symptoms of heart disease can be different in men and women. Our understanding of what a heart attack looks like and what a heart attack feels like is derived from clinical trials which are traditionally enrolled at least 80% men, meaning that typical symptoms reflect a male patterning of coronary disease, which is less often shared by women. Angina is the most common symptom in men and women, but women with angina have a higher rate of sickness and death from their heart attack. While about 55% of men have this typical, almost sort of, the picture that we commonly associated with heart disease, this pattern is only seen in 28% of women. Chest pain in women is often felt differently, with women describing burning or sharp pain, pain that wakes them up from sleep, pain that happens when they're uncomfortable, and they have a higher incidence of jaw, throat and shoulder pain. In fact, many women have absolutely no chest pain whatsoever when they're having a heart attack. And this figure is around 42%, so it's a lot of people. These non-chest pain symptoms, which are encountered both in women and in men, but seen predominantly in women, remain under-recognised and understudied, and they remain a barrier to timely and effective management. These symptoms can include fatigue, dizziness, breathlessness, sleep disturbance. And as I was saying at the lunch, one of the things that I note as a clinician are sometimes people will come in and they'll say, look, I don't know what's wrong with me and I can't really explain what I'm feeling, but something is not right. And it's those people who have actually trusted their instincts and have been advocates for themselves and have pushed to actually get help. These are the people where we often find there is something wrong, and it's sort of a relief that they actually have trusted themselves and got help. These symptoms that I described can be associated with a variety of conditions, so it's not surprising that the diagnosis of heart disease can often be delayed and it can be missed. We know that women with heart disease are significantly more likely to be sent home from emergency with a diagnosis of reflux, anxiety, gallstones and lung disease. The absence of chest pain in both men and women is associated with a delayed diagnosis during a heart attack, but that delay is on average 20 minutes greater for women compared with men. As a cardiologist, when someone's having a heart attack, we have a saying, and it is that time is muscle. And 20 minutes in the setting of a heart attack is a long time, and it's a lot of muscle. Women have more unfavourable outcomes than men. In addition to the absolute greater number of women dying from heart disease, women have higher rates of death before they reach hospital. 52% of women who suffer a heart attack will not survive to hospital. This is a really high figure, and these are the women that we don't hear about. These are the women that we never see in hospital because they never get there. And this 52% in women is compared with 42% in men. In addition, women who present with acute coronary syndromes are twice as likely to die from their heart attack, and the greatest difference is seen in the first 24 hours and in younger women. Victorian data shows that death rates are at 9.1% for women, compared with 4.2% for men. Women have a higher bleeding risk during intervention, and they have a higher early mortality after bypass. But the trials show, long-term, very strong evidence that the management of coronary artery disease benefits both men and women equally. Australian and overseas studies have consistently displayed that women are less likely to be referred for coronary interventions, and at discharge, despite their high-risk status, they are less likely to receive guideline-based prescription of aspirin, ACE inhibitors, statins and beta blockers. These are all standard, best care therapies in clinical practice internationally. This is occurring despite evidence that the application of guideline-based therapy after a heart attack has been shown to reduce the mortality gap seen between men and women. And it suggests that there are real opportunities to reassess our clinical management and to improve clinical outcomes. There are also some biological differences which contribute, and there is ongoing research to try to understand more about these differences to help to uncover the best way to test and manage women who are at risk of falling between the cracks. And this brings us to evidence. There are some times in life when it's really, really difficult to work out where you've gone wrong. And there are some times in life when it's absolutely obvious. As clinicians, we use evidence to guide best practice and decision making. Yet, as I mentioned earlier, cardiovascular trials have traditionally enrolled mostly men. And even when we look at animal-based clinical trials researching diseases more commonly seen in women, the animals in the trials are more often male. In 2007, the American Heart Association released updated guidelines for the prevention of cardiovascular disease in women, and I think this was a really important positive step, and I think it also highlighted and increased awareness about women and cardiovascular disease. Ironically, women constituted only 30% of the patients in the clinical trials used to actually support these guidelines. Even when enough women are included in trials to actually assess them, only 31% of primary trial publications include sex-specific data. Given that we know that there are biological differences in the cause, symptoms and outcomes between men and women, you can appreciate that basing decisions based on an overall result and just extrapolating the data and hoping that it's going to work, it's really not the best way. We can see from the results that it doesn't work. One area which I think needs to be highlighted is the importance of education of our health workforce. Education of doctors and healthcare providers is absolutely crucial in reducing the burden of heart disease. Doctors have progressed through a medical education and lived in a society where heart disease is seen as a man's issue, with really strong research involving men and minimal research involving women, which just goes on to reinforce that notion that women are at a less risk. There is a growing body of knowledge about women and heart disease, and as this body of knowledge grows, we really need to find an effective way to deliver it to our health workforce through university, postgraduate training, and ongoing professional development. There is absolutely no point in giving women information and encouraging them to go and see their doctors if their doctors don't have the information to actually then go on and implement the latest research and give that person in front of them the best care that they can. In Australia, we have an excellent healthcare system with access to general practitioners, emergency services and hospital medicine for everybody. However, studies show that those at the highest risk are the least likely to access healthcare adequately, and as a result, they miss out. Often the most vulnerable are the most unaware of their own risk. When we look at the disparities beyond gender, we find that women who have the worst outcome are those of Indigenous background, ethnic minorities, and those who are disadvantaged educationally, economically, and socially. These are the women at the greatest risk. These are the women with the worst outcomes. Men within these populations are also at greater than average risk, but they have the advantage of more recognisable disease presentations, a higher rate of evidence-based care when they actually do go to hospital, and they also have a higher incidence of screening as part of work insurance programs, which increases the chance of their cardiac risk factors being identified and increases the chance of them being managed. Heart disease is the greatest threat that women face, the greatest threat to their health and to their life. It's an issue which needs urgent attention. This apparently invisible disease needs to be seen for what it is. At a corporate meeting last year, a man made the comment to me that he understood that the statistics showed heart disease was the number one killer of Australian women, but he personally didn't know any women who had died from a heart attack. As a group of people in this room today, I think we represent a very small, and may I say it, a very privileged sector of our community. It's important to think about who you are, the education you've had, your access to information, where you live, whether you feel safe to go for a walk when you go home, if you get home in time. The majority of people in Australia have several risk factors for coronary disease, and this is really growing with the increasing number of people who are inactive and obese, and with these trends, increasing number of people with diabetes, blood pressure and high cholesterol. Looking at it from a different angle, think about whether you know any women who have seen their doctor and have taken steps like increasing their exercise, eating better, not smoking, losing weight, or taking tablets to manage blood pressure, cholesterol or diabetes. I think it would be fair to say that many, if not all of you, know women who have done these things, and in doing these things have probably prevented heart attacks and strokes. This is the model of what we're trying to achieve. Taking these steps means that these women are reducing their risk, and what we really want to see is these things happening on a much bigger scale, not only around metropolitan but also around regional Australia. Preventative strategies work. Since 2001, there has been an impressive decline in death from cardiovascular disease in women and in men, partly due to improved evidence-based treatment and partly due to better preventative therapy. This has coincided with a push to follow specific guidelines for women as well as for men, and it shows that the incidence and impact of heart disease can be reduced if we take the right actions. That said, we cannot afford to become complacent. For the first time in the last 4 decades, this trend is reversing. The cardiovascular death rates of women aged 35 to 54 years has not only stopped falling, but has now started to increase. It's likely that this reflects the growing epidemic of obesity and the risk factors that it brings with it. And I think it's a really clear warning that we must act now. The young women of today, as well as being at risk themselves, are the parents of our next generation, and their role modelling and their behaviours will shape our future. When I was asked to speak at today's summit, I was really grateful for the opportunity, both personally and professionally. In 2016, we are in a position to improve the knowledge, information and delivery of healthcare to reduce the burden of heart disease in women. We have a real opportunity to take practical steps in order to achieve tangible results. Having said that, I have to admit to you, I have something of a vested interest here today. And it's not just because I have a heart which happens to be female. My vested interest is this. I have a mother, I have a sister, and I have a little daughter. It's her future and the future of her friends that we need to change.